Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Exanthematous drug eruptions, Stevens-Johnson syndrome, and toxic epidermal necrolysis are all considered to be idiosyncratic reactions mediated by T cells and classified as delayed hypersensitivity reactions of type 4. These conditions can vary significantly in severity, with manifestations ranging from mild skin rashes to life-threatening systemic issues. Drug reactions may occur due to the drug or its metabolites acting as antigens that activate T cells. Additionally, small molecules can bind directly to T cell receptors. Stevens-Johnson syndrome and toxic epidermal necrolysis exist on a spectrum of severity. In Stevens-Johnson syndrome, there is less than 10% epidermal detachment of the body surface area, whereas in toxic epidermal necrolysis, more than 30% is affected. Erythema multiforme is another hypersensitivity reaction that should be adequately distinguished from Stevens-Johnson syndrome and toxic epidermal necrolysis. Moreover, drug reaction with eosinophilia and systemic symptoms is a severe adverse drug reaction that can also be life-threatening and requires differentiation from Stevens-Johnson syndrome and toxic epidermal necrolysis. The goals of this content are centered around gaining a deep understanding of the various types of drug reactions, their underlying mechanisms, and the skills necessary to distinguish and manage them effectively. First, it is important to understand the pathophysiology of drug-induced hypersensitivity reactions. In addition, learners should be able to differentiate between exanthematous drug eruptions, Stevens-Johnson syndrome, and toxic epidermal necrolysis. Identifying common medications associated with Stevens-Johnson syndrome and toxic epidermal necrolysis, as well as exanthematous drug eruptions, is crucial in clinical practice. Recognizing the role of genetic factors in the development of Stevens-Johnson syndrome and toxic epidermal necrolysis is also essential. Moreover, a solid understanding of the clinical presentation and diagnosis of Stevens-Johnson syndrome, toxic epidermal necrolysis, exanthematous drug eruptions, erythema multiforme, and drug reaction with eosinophilia and systemic symptoms (DRESS) is fundamental. Another critical aspect is understanding the management strategies for Stevens-Johnson syndrome, toxic epidermal necrolysis, exanthematous drug eruptions, erythema multiforme, and DRESS, emphasizing the importance of early diagnosis and intervention. Additionally, it is necessary to comprehend the role of cyclosporin in the management of Stevens-Johnson syndrome and toxic epidermal necrolysis, including its mechanism of action, recommended usage, and the limitations as per current evidence. By achieving these learning objectives, learners will develop a comprehensive understanding of drug-induced hypersensitivity reactions, encompassing their pathophysiology, clinical presentation, diagnosis, and management. Exanthematous drug eruptions, Stevens-Johnson syndrome, and toxic epidermal necrolysis are skin reactions caused by certain medications. These reactions are classified as idiosyncratic in nature and are mediated by T cells. They fall under the category of delayed hypersensitivity reactions, specifically type 4 hypersensitivity responses. Exanthematous drug eruptions, often referred to as morbilliform or maculopapular drug eruptions, occur due to the interaction between antigen-presenting cells and certain drug compounds. This process begins when haptens, which are created when a drug or its metabolite binds to a protein or peptide, are presented to naive T cells by the antigen-presenting cells. As a result of this presentation, the antigen-specific T cells undergo proliferation and subsequently infiltrate the skin. In this process, they release a variety of signaling molecules, including cytokines, chemokines, and other pro-inflammatory mediators. These substances are responsible for the development of the characteristic signs and symptoms associated with the rash. The pharmacologic interaction concept, which refers to the interaction of drugs with immune receptors, is an alternative theory that explains how certain medications can trigger hypersensitivity reactions. These reactions include exanthematous drug eruptions, Stevens-Johnson syndrome, and toxic epidermal necrolysis. This concept proposes that small molecule drugs or their metabolites can directly activate T cells by binding to T cell receptors. Unlike the traditional hapten model, where a drug or its metabolite must first bind to a protein or peptide to form a complex that is then presented to T cells by antigen-presenting cells, the pharmacologic interaction concept suggests that some small molecules can directly bind to and activate T cell receptors. This direct interaction bypasses the need for antigen-presenting cells to process and present the antigen, allowing the drug or metabolite to trigger T cell activation on its own. The direct binding of the drug to the T cell receptor initiates a cascade of events that leads to T cell activation. This activation results in the release of cytokines, chemokines, and other inflammatory mediators that contribute to the signs and symptoms of drug reactions. The pharmacologic interaction concept is particularly relevant for understanding reactions caused by small molecule medications or their metabolites, which may not act as complete antigens. It is important to note that, regardless of the mechanism involved, it remains unclear why only some individuals develop a clinical response to a drug while others experience immunologic reactivity without presenting a rash. The process of drug eruptions that cause Stevens-Johnson syndrome and toxic epidermal necrolysis is complex and involves a T cell-mediated hypersensitivity reaction. Stevens-Johnson syndrome and toxic epidermal necrolysis are related disorders that exist on a spectrum of severity. Stevens-Johnson syndrome involves less than 10% of body surface area epidermal detachment, while toxic epidermal necrolysis entails more than 30% epidermal sloughing. The process begins when an individual is exposed to a drug, which acts as a foreign substance. This drug can be either a small molecule or one of its metabolites. In certain instances, the drug functions as a hapten, binding to a protein or peptide and forming a complex that is then presented to T cells. According to the pharmacological interaction concept, small molecule drugs may directly interact with and activate T cell receptors without the need for processing by antigen-presenting cells. This initial exposure leads to the sensitization of the immune system, particularly involving T cells. Antigen-specific T cells become activated and start to proliferate. These activated T cells, especially CD8 positive cytotoxic T lymphocytes, accumulate in the epidermal blisters. The cytotoxic T lymphocytes are the primary effector cells involved in this process. The activated T cells release substances such as perforin and granzyme B, which are cytotoxic and can kill keratinocytes. In addition, CD8 plus T lymphocytes and natural killer cells secrete granulysin, a substance capable of inducing keratinocyte death without requiring direct cell-to-cell contact. Fas ligand, known as FASL, is also involved in keratinocyte cell death. Certain drugs may induce the upregulation of FASL in keratinocytes, ultimately leading to cell death through a death receptor-mediated apoptotic pathway. Serum FASL, which is a protein found in the blood, plays a significant role in the context of severe cutaneous adverse reactions to drugs like Stevens-Johnson syndrome and toxic epidermal necrolysis. In patients with Stevens-Johnson syndrome and toxic epidermal necrolysis, serum FASL concentrations tend to be elevated. This increase can be detected as early as 4 days before any mucosal involvement occurs. Due to this early elevation, Serum Fazl has been investigated as a potential predictive marker for these severe conditions. Measuring serum Fazl levels could aid in identifying patients at risk of developing these life-threatening diseases early on. The Fazl protein has the ability to bind to the Faz receptor, which is present in various cells, including keratinocytes, the primary cells of the epidermis. Upon binding, Fazl triggers a process known as apoptosis, or programmed cell death. In the case of Stevens-Johnson syndrome and toxic epidermal necrolysis, the activation of the Faz receptor on keratinocytes by Fazl results in extensive epidermal cell death, which is a hallmark of these diseases. Elevated serum Fazl levels contribute to the death of keratinocytes in Stevens-Johnson syndrome and toxic epidermal necrolysis by activating the Faz receptor. This activation leads to the detachment of the epidermis, causing the blistering and skin loss observed in these conditions. Overall, the elevated serum Fazl concentrations present in patients with Stevens-Johnson syndrome and toxic epidermal necrolysis serve as a potential early predictive marker for these diseases, sometimes appearing several days prior to mucosal symptoms. Epidermal damage and detachment occur when keratinocytes die, leading to epidermal necrosis, which is a key feature of Stevens-Johnson syndrome and toxic epidermal necrolysis. Subepidermal bully may form as extensive cell death, and blistering lead to the detachment of the epidermis from the dermis. This process results in large, confluent erosions and blisters. In some cases, a Nikolsky sign may be observed. This sign refers to the sloughing of the epidermis when direct pressure is applied to the skin. The clinical manifestations of the condition typically begin with prodromal symptoms, which include fever, malaise, rhinitis, sore throat, and myalgias. These early signs are followed by the abrupt onset of a macular rash that may appear as target lesions. As the rash progresses, it becomes confluent, leading to dermal-epidermal dissociation. Involvement of mucous membranes is common and may present as erythema, blistering, sloughing, or necrosis. The disease progresses rapidly and can result in life-threatening systemic complications. The role of metabolizing enzymes and transporters is crucial in determining the intracellular concentrations of reactive metabolites. Enzymes such as cytochrome P453A4 and 2C9, along with transporters like multi-drug resistance protein 1, organic anion transporter 1, and PPT2 may contribute to the increase of these metabolites. This increase leads to oxidative stress, which plays a significant role in the immunologic response. Specific drug targets have also been identified in relation to Stevens-Johnson syndrome and toxic epidermal necrolysis. Cyclooxygenases 1 and 2 carbonic anhydrase 2 and sodium channel 2 alpha are drug targets that have been highly associated with the disease. This association suggests that medications acting on these targets are more likely to trigger the condition. Furthermore, genetic predisposition is a factor that contributes to an individual's susceptibility to Stevens-Johnson syndrome and toxic epidermal necrolysis. These two severe drug-induced reactions are characterized by a complex interplay of immune and inflammatory mechanisms that lead to extensive keratinocyte death and epidermal detachment. The underlying process involves T-cell activation, the release of cytotoxic substances, and apoptotic pathways. These mechanisms culminate in the characteristic blistering and skin loss associated with the disease. Certain human leukocyte antigen alleles, also referred to as major histocompatibility complex 2 in many sources, can assist the immune system in recognizing specific drugs that may cause adverse reactions. Notably, some HLA alleles are linked to a severe condition known as toxic epidermal necrolysis induced by sulfonamides in European populations. One such allele, HLA-B12, was the first to be identified in relation to sulfonamide-induced toxic epidermal necrolysis among Europeans. Another allele, HLA-B15:02, is associated with a different drug reaction called Stevens-Johnson syndrome or toxic epidermal necrolysis that is induced by a combination of trimethoprim and sulfamethoxazole in Thai patients. Additionally, the allele HLA-C08:01 has also been linked to trimethoprim and sulfamethoxazole-induced Stevens-Johnson syndrome or toxic epidermal necrolysis in Thai individuals. The existing charts and lists of medications that are identified as common or high-risk triggers for Stevens-Johnson syndrome and toxic epidermal necrolysis are extensive. In fact, they are far too extensive to cover comprehensively in this section. Therefore, I will review the key drugs that you are likely to encounter in the emergency department, which pose a significant risk. Additionally, we will delve deeper into certain aspects to provide a thorough understanding of these medications. Sulfonamide drugs are known to significantly contribute to the occurrence of Stevens-Johnson syndrome and toxic epidermal necrolysis. These severe cutaneous reactions primarily arise from an immune-mediated hypersensitivity to the drug. However, the exact mechanisms underlying these reactions are complex and not completely understood. It is also important to note that antibiotic and non-antibiotic sulfonamides may provoke reactions differently. The sulfonamide drug, or more commonly its metabolite, acts as an antigen that is presented to T cells, initiating an immune response. The reactive metabolites of these drugs can lead to oxidative stress, contributing to an immunological reaction. Research indicates that the enzymes involved in drug metabolism, along with certain transporters, can elevate intracellular tissue concentrations of these reactive metabolites. A notable proportion of drugs that are associated with Stevens-Johnson syndrome are metabolized by the cytochrome P450 enzymes 3A4 and 2C9, multi-drug resistance protein 1, organic anion transporter 1, and peptide transporter 2. Furthermore, possessing a slow acetylator genotype has been identified as a risk factor for sulfonamide-induced Stevens-Johnson syndrome and toxic epidermal necrolysis, as it leads to reduced detoxification of these drugs. Despite both categories being classified under sulfonamides, there is an observable difference in cross-reactivity. Cross-reactivity between sulfonamide antibiotics and non-antibiotic sulfonamides, including diuretics, non-steroidal anti-inflammatory drugs, and anti-diabetic agents, is considered unlikely. This is due to the significant structural differences between non-antimicrobial sulfonamides and sulfonamide antibiotics. Anticonvulsants, particularly aromatic anticonvulsants such as phenytoin, carbamazepine, phenobarbital, lamotrigine, oxcarbazepine, and levetiracetam, are known to cause severe skin reactions including Stevens-Johnson syndrome, toxic epidermal necrolysis, and drug reaction with eosinophilia and systemic symptoms. There is a genetic predisposition to these drug reactions. Specific HLA alleles have been linked to a higher risk of T-cell-mediated hypersensitivity reactions, which can occur with anticonvulsant medications. These genetic associations typically depend on the type of reaction, the specific drug involved, and the ethnic background of the patient. A particular genetic defect in drug metabolism may play a significant role in the development of drug reaction with eosinophilia and systemic symptoms. For instance, the presence of HLA*3101 in populations such as Northern Europeans and Japanese has been shown to markedly increase the risk of hypersensitivity syndrome induced by carbamazepine. If a patient has a documented hypersensitivity syndrome due to one specific anticonvulsant, they are at a heightened risk of cross-reactivity with other anticonvulsants, including phenytoin, carbamazepine, and phenobarbital. Additionally, specific polymorphisms in the CYP2C19 gene have been implicated in the risk of developing Stevens-Johnson syndrome or toxic epidermal necrolysis. First-degree relatives of patients who have experienced drug reaction with eosinophilia and systemic symptoms face a 25% risk of developing this syndrome themselves. Underlying health conditions can also increase susceptibility to drug reactions. Patients who are immunocompromised are at a greater risk for adverse drug reactions. Infections such as infectious mononucleosis can elevate the likelihood of exanthematous eruptions when patients take aminopenicillins. Furthermore, individuals with active cancer are more prone to developing Stevens-Johnson syndrome or toxic epidermal necrolysis. Those with a previous history of drug hypersensitivity are approximately twice as likely to experience hypersensitivity reactions to other medications. Interestingly, women may be at a higher risk for developing these severe skin reactions as well. Medication-related factors are crucial to consider. The timing of drug administration in relation to the onset of a rash is significant, as drug reactions typically manifest within 4 to 21 days after starting a medication, although they can appear later in cases of drug reaction with eosinophilia and systemic symptoms. High dosages of medications and rapid initiation of treatment may further elevate the risk of adverse reactions. Patients receiving multiple antiepileptic medications, particularly in combination therapy involving valproate and lamotrigine, might experience carbamazepine toxicity, even at serum concentrations deemed therapeutic. Finally, cross-reactivity is commonly seen among aromatic amine antiepileptic agents. Allopurinol is commonly used to treat gout and is known to be associated with certain hypersensitivity reactions. The HLA-B58:01 allele is strongly linked to an increased risk of these reactions. Individuals who possess this allele are contraindicated from taking allopurinol due to the potential for severe complications. The HLA-A33:03 allele may also contribute to an elevated risk of severe cutaneous adverse reactions triggered by allopurinol. Additionally, individuals with 1 or 2 copies of the HLA-B48:01 allele are at an increased risk of hypersensitivity reactions to this medication. It is important to note that cross-reactivity with other medications does not seem to play a role in the reactions associated with allopurinol. Beta-lactam antibiotics, which include penicillins and cephalosporins, are linked to Stevens-Johnson syndrome and toxic epidermal necrolysis. These conditions are classified as type 4 hypersensitivity reactions. Interestingly, the well-known side chain properties of beta-lactams may not be applicable in this scenario. Non-steroidal anti-inflammatory drugs are also implicated in causing these severe skin reactions. Additionally, antiretrovirals, particularly abacavir, have been recognized as agents that can induce Stevens-Johnson syndrome and toxic epidermal necrolysis. The HLA-B*57:01 allele is a significant genetic marker associated with an increased risk of these reactions. Furthermore, certain polymorphisms in the CYP2C19 gene have been implicated in the risk of developing Stevens-Johnson syndrome or toxic epidermal necrolysis. Other medications known to be involved include aspirin and various analgesics. Quinolones are another class of drugs associated with Stevens-Johnson syndrome and toxic epidermal necrolysis. Lastly, corticosteroids are known to cause a wide range of side effects, yet they are also effective in treating various conditions, including Stevens-Johnson syndrome and toxic epidermal necrolysis. It is important to note that while some medications are frequently associated with certain conditions, reactions can also occur with many other drugs. Any new symmetrical exanthematous eruption may be related to a medication, and identifying as well as promptly withdrawing the suspected drug is critical in managing these conditions. In terms of medication duration, those that cause toxic epidermal necrolysis can be classified into 2 categories: long-term and short-term medications. The most commonly implicated short-term medications include trimethoprim sulfamethoxazole and other sulfonamide antibiotics. Other medications often involved are cephalosporins, quinolones, and aminopenicillins. Among long-term medications, the ones that carry an increased risk include carbamazepine, phenobarbital, phenytoin, valproic acid, oxycodone non-steroidal anti-inflammatory drugs, allopurinol, and corticosteroids. Cross-reactivity is a common occurrence among aromatic amine antiepileptic agents. However, it is infrequent between cephalosporins that have different side chains. Non-antimicrobial sulfonamides are unlikely to cross-react with sulfonamide antibiotics. In terms of the timing of onset, exanthematous drug eruptions typically appear 4 to 21 days after the initiation of the medication. The conditions known as Stevens-Johnson syndrome and toxic epidermal necrolysis usually occur 1 to 3 weeks following exposure to the implicated substance. Drug reaction with eosinophilia and systemic symptom syndrome may arise 2 to 8 weeks after beginning a medication. Erythema multiforme is an acute disease that is usually self-limited. It is characterized by skin lesions that appear as erythematous or violaceous macules, papules, vesicles, or bullae. These lesions are often symmetrically distributed and commonly affect the soles and palms, as well as the backs of the hands and feet. They can also occur on the extensor surfaces of the extremities. Notably, the presence of lesions on the palms and soles is particularly characteristic of this condition. In the past, erythema multiforme was considered to be part of the same spectrum as Stevens-Johnson syndrome and toxic epidermal necrolysis. However, it is now recognized as a distinct disease that is separate from these conditions. This differentiation indicates that erythema multiforme does not share the same spectrum of severity as Stevens-Johnson syndrome and toxic epidermal necrolysis, despite some overlapping features. Drug reaction with eosinophilia and systemic symptoms, also known as drug hypersensitivity syndrome, is a severe and potentially life-threatening adverse drug reaction. It is characterized by a constellation of symptoms that include a distinct skin eruption, fever, and involvement of internal organs. The skin eruption that occurs in dress is typically morbilliform, but it may progress to a purpuric appearance, particularly on the lower legs. Additionally, the skin can exhibit other morphologies such as erythroderma, facial edema, erythema, pustules, folliculitis, or scaling. High-grade fever, usually exceeding 38.5 degrees Celsius, is frequently present in affected individuals. Furthermore, dress can impact multiple internal organs, leading to conditions such as hepatitis in the liver, acute renal failure in the kidneys, pneumonitis in the lungs, myocarditis in the heart, and issues in the gastrointestinal tract and brain, including encephalitis. Liver involvement occurs in more than 80% of cases. Enlarged lymph nodes are a common observation, and laboratory findings often reveal hematologic abnormalities such as eosinophilia and atypical lymphocytosis. Thrombocytopenia may also be seen in patients. Typically, dress develops 2 to 8 weeks after the initiation of a new medication. The onset is often noted to be more than 14 days after the first dose of an antiepileptic drug. However, in the case of most other drugs, the onset occurs within 4 to 21 days. The severity of dress is concerning, with a high mortality rate that may reach as high as 10% or even 47%. The severity varies based on which organs are involved, and it can lead to multi-organ failure. Additionally, dress has been linked to alterations in the metabolism of certain xenobiotics. It can mimic other medical conditions including sepsis and herpes virus infections. Activation of latent or new infections with human herpes virus 6 is also common among individuals with dress. The immune response in drug reaction with eosinophilia and systemic symptoms, often referred to as dress, is believed to be a hypersensitivity reaction. This condition involves the accumulation of reactive arene oxide metabolites, which result from decreased activity of the epoxide hydrolase enzyme. These metabolites have the ability to bind to macromolecules, leading to cellular apoptosis and necrosis. Additionally, they can form neoantigens that trigger T-cell-mediated delayed hypersensitivity reactions, specifically of type 4. When examining skin biopsies from patients with dress, one may observe nonspecific perivascular lymphocytic infiltration. Other findings can include spongiotic or lichenoid dermatitis, along with varying degrees of edema. Several medications have been commonly implicated in the development of dress. Anticonvulsants such as aromatic antiepileptics, including phenytoin, carbamazepine, phenobarbital, primidone, and lamotrigine, are well-known causes of this condition. Oxcarbazepine and levetiracetam have also been associated with it. Sulfonamides, which include various antibiotics and other sulfonamide drugs, are also linked to dress. Moreover, other antibiotics like amoxicillin, ciprofloxacin, and vancomycin may cause this condition. Lastly, allopurinol is another medication recognized as a known cause of dress. The clinical presentation and diagnosis of Stevens-Johnson syndrome and toxic epidermal necrolysis involve different approaches, with clinical evaluation serving as the primary method. However, additional tests or evaluations may be necessary to confirm the diagnosis or rule out other conditions. In diagnosing Stevens-Johnson syndrome and toxic epidermal necrolysis, a thorough clinical evaluation is essential. This diagnosis relies on taking a comprehensive history, conducting a physical examination, and understanding the timeline of rash development. A critical factor in this diagnosis is the extent of skin involvement. In Stevens-Johnson syndrome, there is less than 10% involvement of the body's surface area, whereas in toxic epidermal necrolysis, more than 30% of the body's surface area is affected. An overlap between the two conditions occurs when there is 10 to 30% involvement of the body's surface area. The rash associated with these conditions is characterized by epidermal blistering and necrosis, which can result in significant skin sloughing. Lesions typically appear on extensor surfaces and may also involve the palms, hands, and soles of the feet. The presence of mucous membrane involvement, including the oropharynx, airway, urethra, and cornea, constitutes an important diagnostic feature. One significant finding is the Nikolsky sign, which occurs when lateral pressure applied to intact skin results in the shedding of the epidermis. A thorough patient history is critical in identifying potential triggers, particularly medications. The typical onset of symptoms is within the first 3 weeks of starting a new medication. In some cases, a skin biopsy may be required and is usually performed by a dermatologist. This procedure can help confirm the diagnosis and exclude other conditions. The results of a biopsy typically reveal subepidermal bully, full-thickness necrosis of the epidermis, and perivascular lymphocytic infiltration. Additionally, severity scores such as the SCOR toxic epidermal necrolysis parameter can be employed to predict mortality in Stevens-Johnson syndrome and toxic epidermal necrolysis. This parameter considers factors such as age, heart rate, history of malignancy, initial surface area detachment, levels of serum urea, glucose, and serum bicarbonate. It is also essential to differentiate Stevens-Johnson syndrome and toxic epidermal necrolysis from other conditions, including drug reaction with eosinophilia and systemic symptom syndrome, erythema multiforme, toxic shock syndrome, and staphylococcal scalded skin syndrome. For patients exhibiting mucosal involvement, additional evaluations such as ophthalmologic and gynecologic examinations may prove necessary. Diagnosis and management of drug reaction with eosinophilia and systemic symptoms involves several important steps. A thorough clinical evaluation is essential for forming an accurate diagnosis. This process relies on the clinical presentation of symptoms, a detailed history of drug exposure, and laboratory findings, which may include eosinophilia and indications of internal organ involvement. It is important to note that diagnosing this condition can be challenging because eosinophilia may not appear immediately and the skin manifestations can vary widely in severity. Distinguishing this drug reaction from other severe cutaneous reactions is crucial. Conditions such as Stevens-Johnson syndrome and toxic epidermal necrolysis must be differentiated from this drug reaction because, while it is characterized by significant skin involvement, it typically does not affect the mucous membranes to the same extent as Stevens-Johnson syndrome and toxic epidermal necrolysis. A skin biopsy can be helpful in differentiating this condition from others, allowing for a more accurate diagnosis. The drug reaction is recognized as a severe response to medication that presents with a specific set of symptoms associated with significant morbidity and mortality. Therefore, prompt recognition and effective management of this condition are vital for improving patient outcomes. When distinguishing between Stevens-Johnson syndrome, toxic epidermal necrolysis, and exanthematous drug eruptions, it is essential to consider their severity. Stevens-Johnson syndrome and toxic epidermal necrolysis are more severe and potentially life-threatening conditions compared to exanthematous drug eruptions. In terms of skin involvement, exanthematous drug eruptions do not cause extensive epidermal detachment, while the degree of epidermal detachment is a defining characteristic of Stevens-Johnson syndrome and toxic epidermal necrolysis. Furthermore, exanthematous drug eruptions typically exhibit mild or no mucosal involvement, whereas both Stevens-Johnson syndrome and toxic epidermal necrolysis have significant involvement of mucous membranes. The Nikolsky sign, which indicates the presence of certain skin conditions, is usually observed in Stevens-Johnson syndrome and toxic epidermal necrolysis, but it is not present in exanthematous drug eruptions. Additionally, target lesions may appear in Stevens-Johnson syndrome and toxic epidermal necrolysis, but they are not commonly seen in exanthematous drug eruptions. Key diagnostic steps involve a thorough gathering of history and physical examination. First, it is essential to collect a detailed history, which includes information about the onset and duration of symptoms, potential exposure to allergens or medications, and any changes that have occurred over time. Next, a careful physical examination of the skin is necessary. During this examination, one should note the type and distribution of lesions present and assess for any involvement of the mucosal tissues. It is also important to estimate the body surface area affected. This calculation helps determine the extent of blistering, necrotic areas, or areas that exhibit Nikolsky's sign. This differentiation is crucial in distinguishing between Stevens-Johnson syndrome and toxic epidermal necrolysis. In addition, assessing for systemic symptoms is vital. Look for indicators such as fever, malaise, arthralgias, and any signs of organ involvement, as these can signify the severity of the reaction. Considering a skin biopsy is important as well. A biopsy can confirm the diagnosis of Stevens-Johnson syndrome or toxic epidermal necrolysis, while also ruling out other conditions that may present similarly. Finally, it is essential to review the patient's medications closely. Identify and discontinue any medications that are suspected to be the causative agents in the reaction. Laboratory and imaging tests are not always necessary for diagnosing Stevens-Johnson syndrome and toxic epidermal necrolysis, but they can be beneficial in certain situations. This is especially true when determining the severity of the condition or ruling out other diagnoses. Laboratory testing can provide insights into a patient's health status. A complete blood count can reveal nonspecific findings, such as a reduction in neutrophils, atypical lymphocytes, anemia, low lymphocyte levels, and an increase in eosinophils. A complete metabolic panel is useful to evaluate electrolyte levels, renal function, and liver function. It may indicate issues like electrolyte imbalance, reduced glomerular filtration rate, and liver enzyme elevation. If there is a suspicion of infection, blood cultures should be performed. Although a serum granulysin test could serve as an early predictor of Stevens-Johnson syndrome or toxic epidermal necrolysis, this test is currently not commercially available. Additionally, a nonspecific elevation of the erythrocyte sedimentation rate may be observed. Serologic tests can assist in establishing a diagnosis, but are generally not accessible during acute phases. Other considerations for testing may include a heterophile antibody test for mononucleosis, a throat swab for rapid assessment, and a culture for group A streptococcus to check for scarlet fever. Imaging is generally not utilized for Stevens-Johnson syndrome or toxic epidermal necrolysis. However, an ultrasound may be helpful in identifying inflammation in the soft tissues. A skin biopsy is crucial for confirming the diagnosis and excluding other conditions. It typically reveals subepidermal blisters, epidermal cell death, and infiltration of lymphocytes around blood vessels. The severity of illness score for toxic epidermal necrolysis can be calculated on the first and third days of hospitalization to predict in-hospital mortality. This score incorporates factors such as age, heart rate, a history of cancer, initial detachment of skin surface area, and values for serum urea, glucose, and bicarbonate. An ophthalmology consultation should be sought if there is ocular involvement. So, for drug eruptions that present with a rash, laboratory testing is usually not needed. For Stevens-Johnson syndrome and toxic epidermal necrolysis, a skin biopsy is essential for confirming the diagnosis and should be conducted by a dermatologist. Laboratory tests like the complete blood count and complete metabolic panel may be performed to evaluate systemic involvement and monitor the patient's condition. Blood cultures ought to be obtained if an infection is suspected. Imaging is typically not required for Stevens-Johnson syndrome, toxic epidermal necrolysis, or drug eruptions associated with rashes, although ultrasound may assist in assessing soft tissue lesions. Ultimately, the decision to perform specific laboratory and imaging tests should be guided by the clinical presentation, the suspected diagnosis, and the need to exclude other conditions. The management of Stevens-Johnson syndrome, toxic epidermal necrolysis, and exanthematous drug eruptions varies based on the severity of the condition. However, all approaches emphasize the importance of identifying and removing the causative agent. The most crucial initial step in managing Stevens-Johnson syndrome, toxic epidermal necrolysis, and exanthematous drug eruptions is to immediately discontinue any medication suspected of causing the reaction. This step is particularly important for medicines with a short half-life, as early withdrawal has been associated with reduced mortality in severe cases. To manage pruritus, antihistamines can be utilized. Additionally, topical emollients are effective in alleviating dryness and itching. Topical corticosteroids may also be employed to treat inflammation and itching, although they should not be applied to the face or intertriginous areas and are ineffective on blistered skin. Prolonged use of strong topical corticosteroids on the face can lead to a condition resembling rosacea, which is characterized by ongoing redness, burning sensations, and stinging. This condition is often referred to as red face syndrome or corticosteroid addiction syndrome. It is crucial to avoid using potent fluorinated topical corticosteroids on facial areas, genital regions, and skin folds, particularly in young infants. For oozing or vesiculated lesions, cool, wet compresses soaked in Domeburo or Buro solutions, which contain aluminum acetate, can be applied. Supportive care is tailored to the severity of the reaction. Fluid replacement is important to manage dehydration, and patients often require intravenous fluids. Fluid resuscitation should mimic that provided to burn patients, aiming for a urine output of 0.5 to 1 milliliter per kilogram per hour. Nutritional support is best achieved through high caloric enteral feeding instead of parenteral nutrition. Pain control may require multimodal analgesia, and intubation and ventilation could be necessary in severe cases. Wound care should focus on preventing secondary infections. Non-adhesive dressings are recommended, and debridement of blisters is typically avoided as blistered skin can aid in reepithelialization. Topical antibiotics or occlusive ointments can also help reduce the risk of infection. It is important to avoid using sulfa creams. To prevent hypothermia and infection, patients should be kept in a controlled environment with a temperature ranging from 82.4 to 89.6 degrees Fahrenheit or 28 to 32 degrees Celsius, and should be handled using sterile techniques. Hospitalization is an essential aspect of managing patients with Stevens-Johnson syndrome or toxic epidermal necrolysis. These patients typically require admission to a hospital, often in a burn unit or an intensive care unit. It is advisable to transfer them to a specialized medical center, as delays in treatment can lead to higher mortality rates. Wound care for individuals with Stevens-Johnson syndrome or toxic epidermal necrolysis should be comparable to that of burn patients. The process of debridement of blisters is controversial. Some medical sources recommend avoiding this procedure unless there are evident signs of infection, delayed healing, or clinical deterioration. Non-adhesive dressings that release silver are commonly utilized as a first-line treatment approach. Careful management of fluid balance and electrolyte abnormalities is crucial in these patients. Additionally, they are at a high risk of secondary infections, particularly caused by Staphylococcus aureus and Pseudomonas aeruginosa. While the use of prophylactic antibiotics is generally not recommended, obtaining skin cultures is important for guiding therapy if an infection is suspected. Controversial therapies, such as systemic corticosteroids, have sparked debate among medical professionals. Some evidence indicates that these steroids do not enhance patient outcomes and may actually increase the risk of infection. In contrast, other studies suggest that a short course of pulse-dose steroids may be beneficial if administered early in the disease progression. Intravenous immunoglobulin is another therapy that remains controversial. However, it may be considered for patients facing severe or refractory cases. Plasmapheresis is an option that can be explored, but it should be done in consultation with a specialist. Cyclosporin has also been studied as a treatment for Stevens-Johnson syndrome/toxic epidermal necrolysis. In terms of additional consultations, patients with ocular involvement should have an ophthalmology consultation. Early consultation with dermatology and plastic surgery can also be advantageous for patient care. Continuous monitoring of patients is crucial to identify complications that may arise. These complications can include metabolic abnormalities, sepsis, multi-organ failure, pulmonary embolism, and gastrointestinal hemorrhage. Important considerations regarding toxic epidermal necrolysis include the severely ill score for toxic epidermal necrolysis. This score is a validated tool that accurately predicts in-hospital mortality for patients suffering from this condition. It is crucial to avoid sulfa-based medications, including silver sulfadiazine, as they can exacerbate the situation. Using air fluidized beds may enhance patient outcomes by supporting re-epithelialization and reducing the risk of infection. The management of conditions such as Stevens-Johnson syndrome, toxic epidermal necrolysis, and exanthematous drug eruptions involves prompt identification and removal of the causative agent. Care should be supportive, with specific treatment tailored to the severity of the individual's condition. Stevens-Johnson syndrome and toxic epidermal necrolysis are severe conditions that necessitate specialized care, whereas exanthematous drug eruptions are usually treated symptomatically with careful monitoring. Cyclosporin is a treatment option for Stevens-Johnson syndrome, toxic epidermal necrolysis, and Stevens-Johnson syndrome/toxic epidermal necrolysis overlap syndrome. These conditions are severe skin reactions that are often triggered by medications. The role of cyclosporin in treating these syndromes primarily involves immunosuppression. Cyclosporin acts as an immunosuppressant by targeting the functions of T lymphocytes. It inhibits macrophage activity and suppresses the activation of the Fos receptor, Fos ligand system. Additionally, cyclosporin inhibits the activation of CD8 T cells, which can help reduce the process of apoptosis. Another significant aspect of cyclosporin is its inhibition of interleukin-2. This cytokine plays a crucial role in promoting inflammation. Furthermore, a study involving 2 patients with toxic epidermal necrolysis found that cyclosporin effectively reduced the presence of CD95, also known as the Fos receptor, in both clinically involved and non-lesional skin. In contrast, patients who only received supportive care showed a marked increase in CD95-R. Importantly, studies indicate that cyclosporin is associated with a noteworthy reduction in mortality among patients suffering from Stevens-Johnson syndrome and toxic epidermal necrolysis. Specifically, there were 43% fewer deaths recorded in patients treated with cyclosporin compared to those who were not. Cyclosporin works by targeting specific components of the immune response involved in skin reactions. Stevens-Johnson syndrome and toxic epidermal necrolysis are believed to be immune responses to external agents. Cyclosporin inhibits interleukin-15 and interleukin-17, which are significant drivers of tumor necrosis factor alpha. The drug is thought to prevent the progression of Stevens-Johnson syndrome to toxic epidermal necrolysis by reducing the apoptotic pathway in non-lesional skin. It appears that while cyclosporin does not inhibit the initiation phase of these syndromes, it does downregulate the CD95 apoptosis pathway, effectively blocking drug-mediated apoptosis. Additionally, cyclosporin reduces the inflammatory cytokines during the amplification phase of the disease. The typical dosage of cyclosporin is 3 mg per kilogram of body weight per day when administered orally or 1 mg per kilogram per day when given intravenously. This treatment should continue until there is complete re-epithelialization. After that, the dosage should be gradually reduced by 10 mg every 48 hours. In another study, a dosage of 5 mg per kilogram per day in 2 divided doses was utilized. Cyclosporin treatment should ideally begin after any potentially offending medications have been discontinued. Cyclosporin can be effective on its own or in conjunction with other treatments, such as intravenous immunoglobulins. A recent study recommends cyclosporin as a first-line treatment for epidermal necrolysis. A meta-analysis has identified cyclosporin as one of the most promising systemic immunomodulating therapies for Stevens-Johnson syndrome and toxic epidermal necrolysis. A comprehensive review of studies involving cyclosporin has shown that it has significant potential to halt the progression of these diseases and improve wound healing. One study noted that the progression of the eruption stopped within 12 hours of commencing treatment with cyclosporin, and reepithelialization of the erosions occurred within 96 hours. Additionally, a study comparing cyclosporin to intravenous immunoglobulins found that there were 43% fewer deaths associated with cyclosporin usage. Another study with 22 participants compared cyclosporin to other treatments, including intravenous immunoglobulins and corticosteroids for Stevens-Johnson syndrome and toxic epidermal necrolysis. In this study, 4 participants died, 1 who was receiving cyclosporin and 3 who were treated with intravenous immunoglobulins. There is limited evidence available regarding the treatment of Stevens-Johnson syndrome and toxic epidermal necrolysis. Most studies conducted are retrospective and uncontrolled, often involving a small number of participants. There exists a wide variability in the dosage, duration, and treatment regimens, with no established international dosing standards for systemic therapies. Moreover, there is a need for studies that compare cyclosporin with alternative treatments such as etanercept, intravenous immunoglobulin, and corticosteroids. One particular study that compared cyclosporin with IVIG was based on observational data, and the outcomes were uncertain due to a lack of confidence in the evidence presented. Several studies have also failed to report on important factors such as the time taken for complete reepithelialization, length of hospital stay, or adverse effects that might lead to the discontinuation of therapy. A review of 10 studies involving biologics, specifically infliximab or etanercept, in treating Stevens-Johnson syndrome and toxic epidermal necrolysis in children did not provide a clear effect estimator for these biologics. Although a meta-analysis indicated a survival benefit associated with cyclosporin, this result was not confirmed in the current review since it included predominantly retrospective studies. Currently, there is a study underway that evaluates the effectiveness of cyclosporin compared to etanercept and best supportive care. Further research is necessary to explore the potential benefits of using cyclosporin alone or in combination with IVIG during the initial treatment phase for Stevens-Johnson syndrome and toxic epidermal necrolysis. Cyclosporin presents a promising treatment option for Stevens-Johnson syndrome and toxic epidermal necrolysis due to its immunomodulatory properties, which help reduce inflammation and promote healing. It is often used in conjunction with other treatment modalities, including supportive care and, in some cases, corticosteroids. This is a detailed review of a complex medical scenario focusing on hypersensitivity reactions related to drug exposure. These reactions include exanthematous drug eruptions, Stevens-Johnson syndrome, and toxic epidermal necrolysis, all of which are considered to be mediated by T cells and classified as delayed, type 4, hypersensitivity reactions. They occur as a result of the body's immune response to a drug or its metabolites. In the case of exanthematous drug eruptions, antigen-presenting cells present hapten molecules, drugs, or their metabolites attached to proteins to T cells, which trigger a maculopapular rash. The pharmacological concept, known as the pharmacological interaction with immune receptors, explains that small molecule drugs can directly activate T cells by binding to T cell receptors without the need for processing by antigen-presenting cells. Stevens-Johnson syndrome and toxic epidermal necrolysis involve cytotoxic T lymphocytes that release substances such as perforin granzyme B and granulysin. These substances lead to the death of keratinocytes and detachment of the epidermis. The severity of these reactions varies, with exanthematous eruptions generally being mild, presenting as widespread, symmetrical maculopapular rashes. Stevens-Johnson syndrome involves less than 10% of the body surface area being affected, whereas toxic epidermal necrolysis involves more than 30%. Common drugs that can induce Stevens-Johnson syndrome and toxic epidermal necrolysis include sulfonamide antibiotics, anticonvulsants, allopurinol, beta-lactam antibiotics, nonsteroidal anti-inflammatory drugs, and antiretrovirals. Exanthematous drug eruptions are often associated with antimicrobials, anticonvulsants, antihypertensive agents, and nonsteroidal anti-inflammatory drugs. Genetic predisposition plays a significant role in the development of these hypersensitivity reactions. Specific human leukocyte antigen alleles, such as HLA-B12 and HLA-B15:02, are associated with a higher risk. Additionally, individuals who are slow acetylators are at increased risk of developing sulfonamide-induced reactions, and polymorphisms in the enzyme cytochrome P452C19 have been implicated in the risk of Stevens-Johnson syndrome and toxic epidermal necrolysis. Clinically, exanthematous eruptions present as widespread, symmetrical rashes composed of macules and papules, usually with minimal or no involvement of mucous membranes. Stevens-Johnson syndrome and toxic epidermal necrolysis involve blistering and necrosis of the epidermis with mucous membrane involvement and a positive Nikolsky sign, indicating epidermal detachment. Erythema multiforme is characterized by target-shaped lesions with 3 distinct color zones, often appearing symmetrically on the palms, soles, and extensor surfaces. Drug reaction with eosinophilia and systemic symptoms features a morbilliform skin eruption accompanied by fever and internal organ involvement. Diagnosis of these reactions is primarily clinical, based on the appearance and distribution of the rash, as well as patient history. Skin biopsies are particularly important for confirming cases of Stevens-Johnson syndrome and toxic epidermal necrolysis. The extent of skin involvement helps differentiate between the two conditions. The timing of onset varies. Exanthematous eruptions usually develop between 4 and 21 days after starting a medication. Stevens-Johnson syndrome and toxic epidermal necrolysis typically occur within 1 to 3 weeks of drug exposure, and drug reaction with eosinophilia and systemic symptoms tends to develop between 2 and 8 weeks. Initial management involves immediate discontinuation of the suspected causative drug. Exanthematous eruptions are generally managed with symptomatic relief, whereas Stevens-Johnson syndrome and toxic epidermal necrolysis require hospitalization, often in specialized burn units or intensive care units. Treatment involves fluid replacement, wound care, and infection prevention. Erythema multiforme is usually treated with topical steroids, antihistamines, and systemic steroids if mucosal involvement is present. Drug reaction with eosinophilia and systemic symptoms is managed by stopping all suspected drugs and providing supportive care, including corticosteroids. Stevens-Johnson syndrome and toxic epidermal necrolysis are the most severe and potentially life-threatening reactions, with mortality rates predicted by severity scores. Drug reaction with eosinophilia and systemic symptoms also carries a high mortality risk. Cross-reactivity between aromatic amine anticonvulsants is common, but cross-reactivity between sulfonamide antibiotics and other sulfonamides is unlikely. Variations in metabolizing enzymes may increase reactive metabolites within tissues, influencing the severity of reactions. Early withdrawal of the offending agent is crucial to reducing mortality in Stevens-Johnson syndrome and toxic epidermal necrolysis. Cyclosporin, an immunosuppressant drug, has been used as a treatment option. It inhibits T lymphocyte function and the activation of the Fos receptor, Fos ligand system, acting as a potent inhibitor of a cytokine called interleukin-2, which promotes inflammation. Studies have shown that cyclosporin may significantly reduce mortality, and it is typically administered at a dose of 3 milligrams per kilogram per day, orally, or 1 milligram per kilogram per day intravenously until reepithelialization occurs, after which it is tapered off. Recent research suggests that cyclosporin could be considered a first-line treatment for epidermal necrolysis. It downregulates the CD95 pathway involved in apoptosis, thereby blocking drug-induced cell death and reducing cytokine-mediated inflammation. However, most existing evidence is preliminary, based on retrospective and uncontrolled studies with small sample sizes. Further research is necessary to determine the potential benefits of cyclosporin alone or combined with intravenous immunoglobulin for treating these severe reactions.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.